the presenter have any disclosures. And today we're going to be talking about an overview of FDA approved treatments for opioid use disorder. So the objectives today are to become familiar with the 3 FDA-approved medications for treatment of opioid use disorder, to be able to help your patient choose between the different treatment options, and to feel comfortable working with your patient on the medication for opioid use disorder. So the key here is detox alone does not work. Medication is what saves lives and keeps people progressing toward their goals. This quote by Walter Ling is, I know, one of Dr. Bott's favorites. Detoxification from heroin is good for many things, but staying off heroin is not one of them. Also one of my favorites. So the detox approach, or the drug-free approach, is the traditional model, but it's really detox without going any further medication support. And it's really only effective in a very small subgroup of people who have high motivation to stay off, but also have very stable environments that would support them from not relapsing. But otherwise, without medications, what we found in repeated studies over time is that up to 90% of patients who detox will relapse on opioids in the first 1 to 2 months. And of course, that's very dangerous with decreased tolerance. There's much increased risk of death from a relapse. And so of those who relapse, some will die of an overdose. So you can see here in this study from the Lancet, a trial of buprenorphine where patients were maintained on the medication and patients who underwent a detox. And so you can see here that for patients who underwent a detox and then continued on placebo, that after a detox, after 1 week, the number who remained in treatment plummeted, and there were 4 deaths in this population. This study would not be repeated, I don't think, but in the patients who stayed on buprenorphine, there were 0 deaths, and you can also see that there was high treatment retention, which is key also to survival. So we'll talk about the role of medications. So talking about methadone, which has been around the longest, our full agonist medication, lots of studies have been done on methadone supporting its utility, and we see lots of benefits. So we see decrease in heroin use by about 50%. We see a decrease in HIV infections by 4-fold. We also significantly see an increase in employment by 24%, a decrease in criminal activity by 60%. And less incarceration, less high-risk behaviors, more child support payments, and importantly, people are 3 times as likely to remain in treatment. So as we saw with buprenorphine, again, the importance of staying in treatment is key to survival. Same with methadone. We also see improvement in terms of keeping people in treatment for their hepatitis C. Oh, great, and Dr. Bott is here, so I'll turn it over to the expert here. That would be great at the next slide. And we also see decreased mortality when patients stay on treatment. It is cost-effective treatment for patients to remain on methadone. And we also know that patients who are out of treatment are 6 times more likely to become HIV positive than those who remain in treatment. So Dr. Bott, did you
yeah, let me see if it. Hi everyone. Sorry, I wasn't able to log on right on time.
Can I give
thanks,
you
Dr.
control
Jacob.
of this, or do you want to open your own slides?
I can try to open them here.
Okay, I'll stop.
Let me see. Let me see if I can. Okay. Bear with me just once. Yeah, and in addition to the kind of the vast benefits that Dr. Jacobson mentioned, the other thing to think about is really this improvement in all of these high risk behaviors, right, or high risk activities, which have been shown with maintenance or ongoing treatment for opioid use disorder, which in turn improve outcomes on a variety of different parameters. This is a very old study. I believe University of New Mexico was actually one of the sites for this study from over 2 decades ago. which looked at sort of crime, which is often a concern that's raised when it comes to methadone maintenance treatment. But in this big study, what they actually showed is that when patients with opioid use disorder were again on maintenance treatment with methadone, sort of crime went down significantly. And that's been shown also more recently in other places, for example, within the city of Baltimore. And some other thoughts just in terms of general treatment is that medication often, while in opioid use disorder, it is kind of the centerpiece of our treatment. That's what really allows us to improve outcomes and save lives. That often allows us, to use that hook to then provide more comprehensive care, including psychotherapy, counseling, case management, healthcare, to allow us to treat all the underlying psychiatric as well as medical things, and work with our patients to address some of the social barriers they may have to optimal health, as well as working with our patients to allow them to meet their goals, create more positive social networks, etc. So now in the next few minutes, we'll just do an overview of our FDA-approved medications before we kind of start delving deeper into it. And our medications include methadone, which we talked a little bit about. Methadone really has been around the longest. It's been the FDA-approved medication since 1973, I believe, when it was approved for maintenance treatment of opioid use disorder. It is highly effective, saves life, yet it is also a highly controlled medication. It is a Schedule II medication according to the Controlled Substances Act, right? And so it's highly regulated. It can only be dispensed if it's being used for treatment of opioid use disorder. It cannot be prescribed out of our offices. It can only be dispensed from what's called an opioid treatment program, which are also, colloquially called narcotic treatment programs, or even methadone clinics, for example. It is a full mu agonist, so it allows us really to titrate up to doses where it can really help control someone's cravings as well as withdrawal symptoms. And it is a good medication. Certainly it's effective, but there are many treatment barriers. It is out of the medical mainstream. There is often a stigma of specialized clinics that, of someone going to an opioid treatment program can come with stigma. The clinics can be few and far between. So even if you think about New Mexico, there are several in the Albuquerque metro area, but then it really dwindles, right? There is one in Belen, one in Santa Fe, one in Farmington, one in, I believe, Roswell, Las Cruces, but other parts of the state really don't have it. So, and that combined with that daily dosing requirement, especially early in treatment, can create a significant barrier to accessing care for many of our patients, right? And buprenorphine, at least in part, is the solution. Buprenorphine really has been used in Europe for treatment of opioid use disorder since the 1980s, late 1980s, I believe. And with gathering data of safety, of efficacy, it was approved in the United States in 2002, but with restrictions, right? So initially the law said that it could only be prescribed by MDs and DOs, physicians, and only with an 8-hour training, which would allow them to obtain a buprenorphine prescribing waiver. Since then, laws have tried to address that barrier to improve access to care. So for example, in 2017, CARA, Comprehensive Addiction and Recovery Act, allowed nurse practitioners and physician assistants to obtain their X-waiver to prescribe buprenorphine, but only after a 24-hour training. More recently, I believe in 2020, the Support Act extended their prescribing privileges to include nurse specialists, nurse anesthetists, nurse midwives, but also with a 24-hour training. And most recently, in April of 2021, an order from the Department of HHS, Health and Human Services, created an exemption or exception pathway towards obtaining the buprenorphine prescribing waiver, which says that any of those qualifying professions can now obtain that buprenorphine prescribing waiver, even without completing the training requirement, as long as they agree to treat no more than 30 patients at any given time. So hopefully that will also allow more practitioners who may not be able to complete the training to start to prescribe buprenorphine. At the same time, we want to make all those resources available, right? We want to provide trainings, at your own pace, at your own convenience, right? So you can keep building up those skills needed to provide standard of care treatment. Buprenorphine, unlike methadone, is a partial agonist. So there is a ceiling effect, which really makes it a whole lot safer in overdose. If you look at, many studies, right? It's approved as both films and tablets, both are sublingual. There is also an injectable long-acting formulation, as well as an implant, which is actually off the market at this point, but it is FDA approved. And generally the dosing range is 4 all the way up to 32 milligrams, with most patients these days in the age of fentanyl stabilizing between 16 and 24 milligrams of buprenorphine. The trick with buprenorphine is the initiation, because if it's taken too soon after using another substance, it can precipitate withdrawal. And we've been seeing more and more of that precipitated withdrawal phenomenon when people have been using illicit opioids. And that's something we go into a lot over the next 10 weeks or so. So the idea here is continuity of care, continuity of treatment that's private, that's confidential, and allows a patient to live his or her life even as they receive this treatment, right? It seems to be roughly as effective as methadone at reducing opioid use, and treatment retention is slightly less, but roughly equivalent, and it's a whole lot safer and a lot more patient-centric. So one of the key things I like to think about is that for most patients, buprenorphine really makes sense as being the first-line medication, with methadone maybe being reserved for patients whose illness may be more treatment refractory, right? And this is just a Cochrane review that really shows that buprenorphine and methadone do about equally well in terms of reducing opioid use, but methadone has slightly better treatment retention, right? And our third FDA-approved treatment is Naltrexone, which is an antagonist. It's an opioid blocker. Both oral pill and injectable Naltrexone are both approved by the FDA for treatment of opioid use disorder. But as the slide points out, the daily oral pill is not very effective for opioid use disorder. And we really ought to be thinking about the injection if we are going to use Naltrexone to treat opioid use disorder. And the injection is an intramuscular injection given every 4 weeks. And it can be an effective strategy for many patients. And some of the newer studies have shown that once someone gets started, whether they're on injectable naltrexone or buprenorphine, outcomes are roughly similar. But it's a whole lot more difficult to actually get people started on naltrexone. And that's the big barrier, I think, to treatment. Because roughly minimum of 30% of participants or patients who might, we might try to give injection naltrexone to will never even receive their first injection because of the wait period of 7 to 10 days of being opioid free that is required. That can be very hard for our patients. So one of the big priorities looking forward, in the research world is to figure out ways where we can shorten this initiation time for naltrexone. It's also very expensive. Thankfully, in New Mexico, Medicaid will cover it. But without it, a single injection can cost anywhere from $1,200 to $1,500. On the flip side, it's an antagonist, so there is no addictive potential. It is not reinforcing. So how do we choose, right? So these are just some slides courtesy of PCSS, which is made possible through a federal grant. So who is a good candidate for naltrexone? So there are some people who just don't want to be on any opioids, right? Or they're not allowed to be on any opioid-based treatments because of their profession. So for example, commercial pilots, right? Or physicians in many states. Naltrexone becomes a good choice. There's a lot of motivation. There's a lot at stake, and they're not allowed to be on any buprenorphine or methadone, right? In my practice, where I use naltrexone the most are the people who've been on buprenorphine or methadone, have done well, are now tapering off. They're almost done with treatment, and they're anxious. They're anxious. What happens when I stop this medicine? I don't want to relapse. So for time-limited period, I might put them on monthly naltrexone injections while they build up their confidence, their coping mechanisms, their relapse prevention skills, and naltrexone can simply be discontinued. I've also had some patients who've been kind of not on any medications, have done well, but there is increased stress for one reason or another. So we might put them on naltrexone as a safety net for a period of time. So that's also worked well for me. On the other hand, for agonist treatments, whether it's buprenorphine or methadone, Actually patients with a long history of overdoses, particularly after detoxes, we should be thinking about maintenance agonist treatment, right? Because naltrexone is an antagonist. If patients stop that, if they return to using illicit opioids, the risk of overdose, at least theoretically, is quite high. Methadone in particular is something I always think about when my patients have serious mental illness, are disorganized, homeless, etc. Because we can provide all the treatment, right, including their long-acting antipsychotics, psychiatric visits, case management around them coming into the clinic to receive their methadone, right? Patient choice, of course, matters. The chronic pain piece is important. If someone does has chronic pain that may require opioids, we should be discouraging them from using naltrexone, perhaps, right? Buprenorphine becomes a great initial choice, but for a small group of people, methadone treatment may be necessary, right? And this is just a little comparison slide between buprenorphine and methadone for reference. Next, I just want to take a couple of minutes. How long do I stay in treatment? And the answer is right there, right? For as long as it benefits the patient. Like any chronic illness, we want to make sure that we're providing ongoing treatment. And in fact, we caution patients against stopping the treatment too early. I really work with my patients, make a list of functional goals, revisit those periodically, and really allow, encourage and empower patients to stay on the medicine at least until those goals are met, and maybe for as long as they continue to benefit from it, right? These are just some other things, right? Just little tips that when patients are on the right dose of medicine, they should feel normal. They shouldn't be withdrawing. The craving should minimize, and they shouldn't feel intoxicated or high, right? Cravings may not completely go away. I've had patients who've not used any illicit opioids for years, and they'll still sometimes have the kind of using dreams or cravings, which can be emotionally a jarring experience. And psychotherapy, I think in my experience at least, can be essential in terms of addressing it. If patients are on methadone, EKG monitoring is a best practice. Although it's not a universal practice, it is a best practice, and I think it's a good idea. Similarly, especially if they're on methadone, drug-drug interactions, always check, because methadone interacts with so many things. Next practical tip, right? Naltrexone cannot be combined with any opioids, including methadone and buprenorphine. Sometimes this does come up. So I really wanted to list that. And when we help our patients make a choice, I think one of the many reasons why buprenorphine is a good initial choice is that if someone gets started on methadone and then can't tolerate it, it's very difficult to switch from methadone to buprenorphine. On the other hand, it's a lot easier to switch from buprenorphine to methadone. That's actually a fairly straightforward process, right? So that might also help determine which one to start first. Let's see, need to be in minimal withdrawal, right? At least mild to moderate withdrawal to start buprenorphine. I do discourage patients from using other substances, but I don't discharge them from treatment if they do use other treatments. We try to intensify treatment and try to keep patients in treatment for as long as necessary. And just a little plug for something Dr. Jacobson certainly does, which is integrated clinics, integrating primary care, behavioral health, psychiatric care, case management, everything under one roof, which may improve outcomes for our patients. So we will stop here. It is right at 12:30. So